Welcome, everybody. I'm Darlene Hutton with QRS Educational Services, and this is part 5 in our video series called Airway Management. In this video, we will be looking at inserting a laryngeal mask airway. It is by far the easiest advanced airway to insert, and in some settings, nurses have been trained to insert this when there's not a physician or an RT readily available to handle a compromised airway. So you would not put it in, though, unless you've had the proper qualifications and training and you've got the knowledge to do it. The contraindication to putting it in is somebody who is imminently going to be at risk of aspiration from vomiting. So morbidly obese, hugely distended abdomen, a very pregnant patient. But for an elective surgical procedure where your patient is NPO and it's a low risk kind of procedure, these are the most frequent types of advanced airways that go in. They are considered blind intubation. And what that means is you do not need a laryngoscope. You're basically just going to shove the tube in until you meet resistance. And when you meet resistance, it's because the tip of the mask has entered into the esophagus. So just stop at that point. You are then going to attach your filter. You're going to inflate the mask with a syringe. You're going to attach your ambu bag, and you're going to do your 5-point check. You're going to check over the abdomen to make sure you hear no air there. And then you're going to do 2 breaths into the lungs while you auscultate the anterior lung fields, and you'll do 2 more breaths to auscultate the lateral lung fields. So let's take a look at this. The sizing for LMAs are contingent on the patient's approximate weight. This is a size 5, and it would be for an adult about 30 to 50 kilograms. The syringe that you do require to inflate is larger than what you would use for a syringe for an endotracheal tube. And again, good practice is you want to make sure that there is no leak. So you inflate to check that there's no air leaking. And you can keep that attached. Next is we are going to ensure that it is well lubricated. When we put it in, hold on to the jaw, push in until you meet resistance, right about there. And it will come out slightly as you inflate the cuff. And remember, the secret is not in the amount of air, but it's in this being a soft grape sensation. And then always disconnect your syringe from the bulb so it's not leaking out. Then you attach your airway, your filter, and your ambu bag. And let's see what we have. So with our stethoscope, you're going to be listening for air going into the stomach, which you should not hear. Good, no air in the stomach. And then you're going to do your 2-point check, anterior and lateral. And then you would be administering 1 breath every 6 seconds. If this is a cardiac arrest, you're going to be doing continuous compressions while you administer 1 breath every 6 seconds. If it is a respiratory arrest, you won't obviously be doing compressions, but you will still be doing 1 breath every 6 seconds. If your patient is about to vomit, just take it out. You do not need to worry about deflating because it hasn't gone past the vocal cords, and therefore it will not cause any damage when it is withdrawn. Let's take a look at a couple of other forms of LMAs. This here is a different version, and it is to promote the potential of feeding in an endotracheal tube. Bit of a different configuration. This is called a Fastrach. The other one that I'm seeing and hearing a lot more people talk about is called the iGel. And the iGel is an LMA that does not require the patient or the mask to be inflated. It's kind of a jelly sensation. So for this, what you're going to do is you're going to lubricate, insert, inflate. Oh, you don't inflate. Right. So used to inflating these things. There's only one way to turn these on or put these on. And then you would be doing your 5-point check to make sure that there is air going into the lungs and not the stomach. So that's it for the LMA. If you like this video, please subscribe and give me a like. Thank you so much.